This is a 34-year-old male who had a tibial nail placed at an outside hospital previously after an accident. He also had a fibular plate placed, had continued pain and lack of healing upon evaluation in my office. His pain corresponded with the non-union evident on plain film. I subsequently ordered a CT scan which also showed the relatively atrophic non-union as well as well-healed fibula. I utilized the previous surgical incision, which was relatively large as shown here. I created a medial parapatellar arthrotomy and was able to access the proximal tibia through this incision. I placed the opening guide wire at the appropriate point on the tibia and verified this on lateral imaging. The previous nail was relatively buried, so I had to advance the opening guide wire as verified on biplanar imaging into the nail itself. I was able to use an opening reamer at that point to remove bone from the end of the nail to be able to access this. Next, I made an incision over the proximal interlocking screw site. I was able to spread down to the screw without difficulty and remove this in the usual manner. The previous surgeon had placed an end cap on the nail, presumably from depth of insertion. I removed this at this point to allow placement of the extraction bolt as shown here. Now with the extraction bolt secure in the nail, I made an incision distally over the two interlocking screws, which were easily palpable. I spread down and also removed these two screws without difficulty. After removing all the interlocking screws, I gently backslapped the nail to remove this from the tibia. Now, since I removed the previous nail, I was able to start placement of the new nail. Initially, I placed the guide wire and gently tapped this down into the physeal scar. After our wire was verified on biplanar imaging, I began sequential reaming. I initially started at the size of our previous nail and continued in 0.5 millimeter increments up to 2 millimeters larger than the previous nail size. The reaming process shown here not only helps to size the nail and allow for larger nail placement, it also improves the blood flow to the outside of the bone, which should help healing. Now that I was done reaming, I was able to assemble the nail and verify that the jig lined up correctly. I inserted the tibial nail into the tract that I reamed out, and this sat nicely over the guide wire. I continued to gently tap this in until this was fully seated into position. Jerking of the nail while in the canal is not recommended. You can use the tibial crest to help with your alignment off the jig to ensure that the rotation is appropriate for the limb. At this point, I ensure that the nail is fully seated so it does not extend into the knee and cause chronic anterior knee pain. Now I drill and place a screw through the nail proximally in order to prevent the nail from retracting into the joint with any continued non-union. Now that the proximal interlocking screw is placed through the jig, I remove the jig and bring the knee up to full extension. Using perfect circle technique, which you can see in some of my other videos, including the femoral and tibial nailing videos, I drill, check, measure, and then place two distal interlocking screws into the nail to help hold this into position. Here are the final CMR images showing a well-positioned nail with one proximal and two distal interlocking screws. I also removed the fibular plate at the end of the nail placement, as this was not necessary for this particular fracture pattern. Here are final images at 1 year post-op showing a well-healed tibia fracture without any evidence of implant failure or loosening. At most recent checkup, 3 years post-operatively, he continued to work as a nurse in the hospice environment. And thank you to Jeff Oddie as well as Dan Buchan for obtaining the footage for this video.